have Dr. Oyebeke still with us, and for this particular topic, for this particular time, is going to be talking about urinary stress incontinence. This is a situation where men and women may not have control of the use of their bladder.
You're quite right. You're quite right.
So can you please enlighten us on what urinary stress incontinence is?
Well, people talk about urinary stress incontinence as one disease process, but it really isn't. It's a combination of a few things that involves the bladder. Urinary stress incontinence, by pure definition, is a situation where, by increasing intra-abdominal pressure, either by cough or by lifting things heavy, you lose urine. That is also different from having urge incontinence, where you feel that you if you feel like you have to go right now. You have to go right now. If you don't go, you lose urine. There's also such a thing as overflow, whereby you don't really, feel the urge to go until your bladder is quite distended, and then you lose it from the excess amount of urine that you have. So there are ways to determine, which is which. There's some tests that we can have. So people always come and say, oh, I'm losing urine. And then the question is, how are you losing it? When are you losing it? Under what condition? We have, a test that we call urodynamics that we do that could tell us, what it is that the individual has. Do they have stress incontinence? Do they have urge incontinence, etc.? When you have stress incontinence per se, what it is most of the times, not only for the elderly, but for everyone. If you have a situation where the bladder neck is down, this is the vaginal canal. If this bladder neck is down, whereby, by increasing intra-abdominal pressure, there's no distinction, there's a funneling of pressure, and the urine comes out on that basis. Then the best thing to do is to, render that neck of the bladder, bring it back into the peritoneal, into the abdominal cavity. That way the pressure is distributed evenly, and then you don't lose urine anymore. That's a surgical correction. There are also situations where, but if you do that surgery on someone who has overflow problem, then you make the situation worse.
How?
So that's makes, because if somebody has a situation where they're retaining urine,
okay,
and then instead of, and then you bring the bladder neck up, instead of giving them medications and treating the bladder itself, you could worsen it in the sense that you're tightening the neck of the bladder. Then the bladder itself may not flow easy. Then that makes the, if you have neurogenic bladder, for example,
okay, that
makes the situation worse. I can show you the equipment that we use,
okay,
to evaluate patients who have that kind of condition.
This is Dr. Soyebeke's office, by the way.
Yeah, so this here is the machine that we use for checking the patients who have incontinence. What they do is they'll come in and you have the individual come in with a full bladder, and then they'll void, and then you see exactly how much urine that they're able to produce.
Discharge.
Because the individual could come in and say, oh, my bladder is full, I can't hold it, and they'll urinate just a little. Then that tells you that their bladder is quite small.
Okay.
And that causes them to go to the bathroom quite often. But if they come in with a normal bladder, they're able to hold over 100 cc's, 150 cc's, then you know at least that the bladder is large enough to hold the urine. Once they're able to urinate, then you check and see what we call post-residual volume, how much urine is left in the bladder after they pee. If they're retaining urine, after they peed here, you could still have a large amount of urine left in the bladder.
Okay.
Then you say, the individual, even without doing any fancy test, you could say this individual is retaining urine. Then after that, you see if you could reproduce the stress incontinence. Then you put a normal saline, you hook the individual on this computer, and then measure pressures, abdominal pressure, pressure in the abdomen, pressure in the bladder, pressure in the neck of the bladder, and do fancy tests to see whether an individual has, detrusor instability, hypermobility, whereby, the individual could be having pure stress incontinence or a combination of those. depending on what it is that you find with the help of the computer, etc., that you could tailor the treatment of the patient to the actual illness that they have. Because individuals just don't come in and say, oh, I have just pure stress incontinence, or I have pure urgency, or I have pure, it's usually a combination of this and this. So you have to find out what, and then tailor the treatment to that patient's need.
I mean, to the patient, they will come to you if they have any issues with their urine. Maybe they're not able to retain the urine and all that. But after you do your test, that is when you come to a conclusion
as to how to treat the patient.
As to how to treat the patient. Now, where does the name stress come in?
Stress is the fact that, you know, the individual, when they're stressed, when they lift something heavy or they push on their abdomen, the urine comes out. That's the stress part of that
the stress
incontinence.
Part.
Right.
So what if in a situation, or when you have a situation where maybe in the absence of stress, they just find themselves not able to control their, or they just find themselves just discharging?
That's the, you know, if you have neurogenic bladder, for example, you don't even know that you're passing urine. Your bladder is overfilled, there's no sensation to it, and the urine just comes out. You know, that's also, you know, you'll be able to pick all that up.
And that is at what age? I mean, usually, like,
it could be some people who have diabetes, you know, tend to have that. But it's more, it's an illness not only of the elderly, but people who are not. But the elderly tends to have a disproportionate proportion of those patients who have that.
Is it because of the decline in the body ability to?
As you get older, you know, the neurologic system doesn't work as much. As you get older, there's an increased, you know, chance that you may be diabetic. As you get older, you take certain medications that may well affect those things.
Are there treatments or?
Oh, definitely. There are treatments. They're ranging from surgery to the use of medications. Even exercises, Kegel exercise is tremendous. If you do Kegel exercises where you're tightening up the muscle of the pelvic area, the levator ani, by doing that exercise, by tight squeezing on that muscle, you can actually build it up in such a way that incontinence will be well controlled. In addition to that, you know, the tissue, the female pelvic tissue may well be thin, but by putting the individual on things like estrogen cream, that will bulk up, you know, the tissue, and that also would help quite a bit with incontinence.
So this incontinence that we're talking about, is it a gender? Is it something that is only I mean, that women are only affected by it, or
the anatomy makes it in such a way, you know, anatomy predisposes women, you know, to incontinence more so than men. Yeah,
so this is not a problem that is as
prevalent among men. No.
Oh, okay.
No, it's not. It's not that prevalent among men, but it is more common among women, I should say, than men.
Than men. Okay.
So people should not, I mean, there's no reason to feel embarrassed or ashamed that you're leaking urine. It's not something that you brought on yourself. It's an illness that you have. It's just like having a headache. If you have a headache, you go to a physician and say, I have a headache. If you're losing urine, it's not a shame to seek medical care, but it's a shame not to. You have to go in and see, is this treatable? And most of the time it is. Yeah,
if you know, there was a time that a caregiver, you know, brought a situation to my attention. The mother, you know, was 88 years old at that time, and she started losing control, you know, of the bladder. And one of the concerns that she had was my mom is going to be using pad. What do you call it?
I know what you're saying.
Yes. So what is that? I mean, does that tell you that there is once you have the incontinence, then there is the next step would be just to go and get a pad?
There's no you know, it doesn't mean that you're forever dependent on the pen.
Okay.
You know, there may be situations where, you know, there may be nothing you could do.
Okay.
You know, the individual is going to be incontinent. If you have Alzheimer's, for example, you know, it may get to a point where, you know, from the illness that you have, you know, you may have incontinence of bowel, incontinence of urine. There are situations like that may not be treatment for.
Okay.
But most people who are, you know, who have no medical illness, all they have is a situation where they're just losing urine. you know, in more of those cases, you can, you know, work them up, and there may well be solution, if not to treat it 100%, but to lessen, you know, the occurrence, lessen the embarrassment that occurs with it, and lessen the infection. Because once you have an area moist all the time with urine, you're bound to have infection, you know, that would make the individual, you know, homebound. They're afraid to go out, not only because of the fact that they're losing urine, but they feel that they're not clean. You see.
Okay, so you did mention something about Alzheimer's. People with Alzheimer's, or they have dementia.
Right.
And I mean, in research, we know that there's a high prevalence of incontinence with people with Alzheimer's.
Right.
So that is not neurologically, I mean, that is not physiologically, that is not a physical disability as such, but rather
it's part of the whole it's part of the illness. The individual may not necessarily be able to control their blood, you know, just like they're not able to control a lot of things. They may not be able to control their bladder and their bowel
because of their
because
mental,
of the overall
the cognitive impairment.
Right.
Okay.
And neurological impairment as well.
Thank you, Dr. Oyebeke.
You're
it's
welcome.
A pleasure having you on the program.
Pleasure's
and
all mine.
Our viewers, I hope you enjoyed this program. If you have any question, please email us or write us, and we'll be here for you. Thank you. And please remember, this information that we provided for you is just for your information only. This information does not substitute for any medical advice. Thank you.